Okay, so this is probably the part that you're really excited about. Now that we've learned about what's going on, you're going to start learning about what shows up on the patient during the inflammatory process. So the cardinal signs of acute inflammation are redness, also known as erythema, heat, swelling, pain, and loss of function. You will be tested on those throughout your entire program as well as on the NCLEX. So it's really important to understand that those are there. So what causes that erythema, the redness, the heat, the swelling, and the pain? You remember our friends? Leukotriene, bradykinin, prostaglandins. Prostaglandins and bradykinin are the ones involved in pain. They're also involved in the redness, the heat, the swelling, as well as histamine. All of those chemokines that are attracting everything, widening the blood vessels, and causing more permeability are causing those. You might be wondering about loss of function. Why does that happen? Well, think about it like if you were to cut your finger over the knuckle. It's going to swell up because all that fluid moves there. It's red, it's painful, but it's also going to be hard for you to bend that knuckle. And that is really due to the pressure that that inflammation is putting on the area. So the local manifestations, again, I gave you this chart here so you guys can study from this. So I would put a big star by this and come back to it. The redness is caused by vasodilation and increased blood flow to the site, as well as the heat. Incapacitation or loss of function is due to tissue damage from the injury, the pain, and that swelling that we just talked about. Pain is a result of the increased permeability of the vessel, all the fluid moving to that area, which is compressing on tissues, and the stimulation of those inflammatory mediators, the prostaglandins, the bradykinin, that are known to elicit that pain response. The exudate and the edema, this is due to fluid accumulating in the tissues because of that increased vascular permeability, and oftentimes it includes both fluid and white blood cells that are accumulating in that extracellular area. Systemic manifestations. So we've been talking about so far local manifestations, or what you see at the site of injury. Now again, I give you an example of a paper cut, but that injury could be happening inside the body. It could be happening to the heart tissue or the kidney tissue, and you'll have that inflammatory process happen the same way no matter where it's happening. Now systemically, which means throughout the body, there are specific manifestations that we see in somebody that has an inflammatory response. We talked about interleukins and different processes, different chemokines telling the hypothalamus to reset the body's temperature and cause a fever. That is exactly what can happen. So that is a systemic effect. It's not happening just at the site, it's happening everywhere. So we have pyrexia, fever. Elevated body temperature helps to stimulate phagocytosis, so it makes the white cells go in and do their job a bit better and eat up the dead tissue. And it can also inhibit microbial growth. We end up with leukocytosis. So leuko is white, cyte is cell, and osis means a lot of. Okay, so leukocytosis is elevated white blood cells. Now your normal count is like 5,000 to 10,000. It varies a little bit depending on the lab, and they'll tell you what the normal is, but typically 5 to 10,000. So we're going to see elevated leukocyte counts in that early inflammation period. But if it's a successful inflammatory response, by about 72 hours, those should be coming back down and coming to normal. So if they're not, or they're getting higher, it's a trigger to tell us this inflammatory process was not successful and there is now an infection going on. So that's what we're thinking about. So again, why does the leukocytosis happen? Because we're bringing in more white blood cells to help to heal the area. We're also going to see an increase in plasma proteins, and there's a few that are specific. There's one known as C-reactive protein, and you'll see this on a lab test as CRP. And that is a test that can help us identify acute phase reactant proteins. These are specific proteins that we see in inflammation, particularly systemic. So if we think there's an inflammatory process going on somewhere in the patient's body, we'll draw their blood and we'll look for this C-reactive protein. And if we see the C-reactive protein elevated, it means that inflammation is happening. That's what it means. And another one that tests for that is called erythrocyte sedimentation rate, which you see is the third little row here, or ESR. And I've given you all of these here. I've given you the normal level for both men, women, or children, or women that are in pregnancy. When we look at the white cell count, you'll see that as a WBC count, again, 5 to 10,000. If it's increased above 10,000, we'll see that during the acute inflammation, but again, it should be going away by about 72 hours. And if it's not, if it's getting higher, it's still higher after that time period, think infection. The differential is looking at the specific cells. Neutrophils are the ones that we see early in that inflammation process. Bands are very immature neutrophils, and they get called up when there's a pretty bad infection. Eosinophils are related to, and basophils are related to some sort of a allergic type of a reaction. Lymphocytes are in the lymph system, and monocytes are mature neutrophils, basically. And they're going to specialize in into the type of white blood cell that's needed. So the erythrocyte sedimentation rate detects red blood cell clumping or stacking that happens as a result of increased fibrinogen levels. That level is going to increase during the inflammatory process. Again, why? Because we're bringing those clotting factors, and fibrinogen is one of them, to the site to try to heal it up. So you're going to see more of them in the blood. So when we look for that ESR, that erythrocyte sedimentation rate, it tells us that there's an inflammatory process being triggered somewhere in the body. So we've talked about C-reactive protein already. Just a note here, a level of greater than 10 milligrams per liter indicates that there is significant inflammation happening in the body. We look for complement activity as well. That's elevated in the inflammatory process, and it signals that there's activation of the complement system. It tends to decrease over time, but it can also happen. It can be decreased just because the body has had to use up all of the complement factors. A couple of other tests, prothrombin time, this is measured in time, and it involves time to coagulate or time to clot, right? So we see increased prothrombin levels resulting in issues with inflammation, but also in some other diseases that we'll talk about later. And then fibrinogen gets elevated during that inflammation process, again, because it is bringing in clotting factors to try to seal off the wound. So how long does it all take? So I've mentioned this several times, and that should be a clue to you that there's a really good chance I'm going to test you on this, because I really, really, really want you to know it. So there are various phases of acute inflammation. The immediate phase starts instantly the second there is an injury anywhere in the body, and it lasts for a few minutes. This is where the tissue damage has occurred. There's a pathogen presence, something that has triggered this release of histamine, the prostaglandins, and the bradykinin. They go in and do their job. So then we end up in the acute phase, and this lasts for a few hours to up to about 3 days. So I keep saying 48 to 72 hours. That's what I'm talking about, this acute phase. This is where the neutrophils are being recruited, the pro-inflammatory cytokines, tumor necrosis factor alpha, interleukin-1, and interleukin-6, all of those that are pro-inflammation. They're going to cause inflammation. They get brought in. We have the pyrogens, interleukin-1, interleukin-6, tumor necrosis factor being stimulated so that we end up with a fever response to elevate the body temperature. Now, the difference in inflammation is the body temperature doesn't elevate as much as it does in infection. So that's another thing that we look for in nurses. So for example, if I have somebody that just came back from surgery where we cut them open, I expect to see some redness, some swelling at the site. I don't expect to see pus. Shouldn't be there. Redness, swelling at the site. Is it going to be painful? Well, we know it is, because prostaglandins and bradykinins are going to be there. So it's going to be painful. And they're probably going to have a low-grade fever, so up to about 100, 100.5. If after 3 days they still have a fever or it's higher than 100.5, that tells me there's probably an infection. If I see that kind of pink redness of the surgical site starting to get worse and worse and worse after this 2 to 3 days when it should be starting to get better, that's a sign that tells me that there's an infection going on. So that third stage is the late acute to the subacute phase, which is between days 2 and 5. This is where the white blood cells have moved in. So we have mature macrophages that are specialized for whatever bug they need to fight off. And we're starting to see some secretion of anti-inflammatory cytokines that are going to start causing the inflammatory process to stop and to start to promote some tissue repair. This is where we're going to have proliferation of fibroblasts, which are going to help to make the clot. We're going to see angiogenesis, which again is a fancy word for creation of new blood vessels, which we absolutely need in order to feed the healing tissue. And those fibroblasts are going to begin synthesizing collagen and new blood vessel formation to restore the integrity of the tissue. The resolution phase is day 5 to 7, where now we have the anti-inflammatory mediators like the lipoproteins and the resolvins and interleukin 10 come into the spot, and they're putting the brakes on the whole inflammatory process. They're saying, okay, everything's done, we're healing everything up, time to back off and slow everything down. And these are going to be involved in not only healing up and removing everything that's remaining, but starting to break down the clot that formed at the site as well. So we want to look at acute versus subacute and that kind of latent inflammation. Acute inflammation injury should resolve quickly, again, 2 to 3 days max. If that inflammation doesn't quickly resolve, it can change into what's called subacute inflammation. And if it lasts more than 6 weeks, now it's going to transition from this subacute to chronic inflammation. And this is where we're going to have migration of a percentage of the lymphocytes and plasma cells to that site of inflammation. When we have prolonged inflammation without recovery, it's going to cause tissue damage and fibrosis or scarring. And if a fever persists, again, I'm adding this here, so highlight that, whatever. If a fever persists for more than about 48 hours or the temperature is high, like 101.5 or higher, then it's likely an infection and not acute inflammation. So as a nurse, you really have to know these signs and symptoms. So how do we treat it? Well, our goal is to reduce blood flow to the local area, decrease swelling, block the action of various inflammatory mediators, and decrease pain. And again, here we're talking about overwhelming or chronic inflammation or inflammation that's kind of lasting too long or it's causing too much pain. So we treat it using that kind of RICE acronym or mnemonic, which stands for rest, ice, compression, and elevation. And then the medications we're going to give are going to block that COX or COX pathway. Again, we're talking about NSAIDs, non-steroidal anti-inflammatories like ibuprofen. They work best on inflammation. And I've listed them out for you here and exactly what they do. So put a star by this because I will probably ask you this on a test and it will definitely come back when you're taking pharm. So aspirin inhibits the conversion of that arachidonic acid to prostaglandins, and it does that to suppress inflammation, reduce pain, and reduce fever because again, prostaglandins cause pain and cause fever. NSAIDs, which are going to be like aspirin, but this is ibuprofen, naproxen, that kind of thing, they are going to inhibit that anti-inflammatory conversion of arachidonic acid to prostaglandins. And then another category are the glucocorticoids, and these are prednisone. This is a pretty powerful medication, and it acts through several mechanisms to interrupt the inflammatory process. So it does that by inhibiting synthesis of chemical mediators, reducing the swelling, the warmth, the redness, and the pain, and suppressing the infiltration of phagocytes and avert tissue damage from the release of different enzymes. It's going to suppress lymphocyte proliferation, which will reduce the components of inflammation that we see, but it also decreases immune response. So it's got some pretty serious side effects. So, as I said, glucocorticoids suppress expression of pro-inflammatory cytokines like tumor necrosis factor alpha, interleukin 1, and interleukin 6 by inhibiting a specific factor called nuclear factor kappa beta signaling. This blocks the phospholipase A2 activity, which reduces the production of arachidonic acid. Remember, that is involved with that COX pathway. So it's going to, and all of its derivatives get blocked too, including prostaglandins, leukotrienes, thromboxane. So it's going to suppress our immune cell activity as well. And that can actually decrease the body's ability to fight infections. So glucocorticoids stabilize lysosomal membranes. They promote anti-inflammatory mediators like the interleukin 10 and the lipocortins, which help to resolve inflammation. And so that's why we use them to reduce really bad inflammation or to prevent organ damage in severe autoimmune disease or to suppress certain reactions like in a transplanted tissue rejection, but they also have very serious risks. And the risks are that they suppress the hypothalamic pituitary adrenal axis, known as the HPA axis, which can result in decreased adrenal action, which is needed. And what will end up happening is if somebody is taking a glucocorticoid steroid and we stop it all of a sudden, like if they don't taper that medication dose, they can trigger their adrenal glands to not be able to work. These medications will increase the risk for infections. They also have metabolic effects. They cause hyperglycemia or too much blood sugar, which can be particularly problematic in people that have diabetes. And they do that because they're causing gluconeogenesis, or the formation of new glucose. They also cause insulin resistance. So it's not a good thing to be giving glucocorticoids or any kind of steroid to somebody with diabetes unless we have to. They're going to raise blood sugar in anybody, though, not just people with diabetes, anybody. They're going to cause the breakdown of protein in peripheral tissue, which will also cause muscle wasting. They can result in osteoporosis because they inhibit that osteoblast activity. Osteoblast, if you remember from physiology, is what helps bone to grow. And they also inhibit calcium absorption, which increases their fracture risk. So a patient on glucocorticoids, increased risk of fracturing a bone. They have cardiovascular effects. They cause sodium and water retention, which increases the risk of hypertension. They also cause dyslipidemia, which is problems with cholesterol, and that will increase the risk of developing atherosclerosis or atherosclerotic plaques in your blood vessels. They also cause mood swings, anxiety, depression, even psychosis. They cause thinning of the skin, easy bruising, and delayed wound healing. So again, we're only going to use glucocorticoids if that inflammatory process is really bad.